So thank you very much, everyone, for coming to our ID series. We are really honored and delighted today to have Dr. Pauline Sockolow giving us a talk about the transitions from hospital to home health care. But before I introduce her, let me go over some housekeeping issues. As you know, the instructions to obtain CME credit are on the screen, and we can also email you the instructions if you provide your address on the sign-in sheet. And now you have until Tuesday to sign in, so do not forget if you want to have CMEs. Our next ID series will be on August 23rd, and we'll be very happy to have Dr. Tanjana Purnell from Johns Hopkins, who will talk about transplantation, kidney transplantation. And the title of her talk is Achieving Transplant Equity, Closing the Gaps in Disparities, Interventions and Research. So again, do not forget to register on the Christian Care portal. And the full ID series is posted on the ACCEL DE-CTR.org site. And finally, we have a tech talk on September 5th by Dr. Jobayer Hossein, who will talk about classification of distinct trajectories in unbalanced longitudinal data, growth mixture models versus clustering. So that will be also a very interesting tech talk. So again, I'm really, really excited to have Dr. Pauline Sockolow here. Dr. Sockolow is Associate Professor in Health Systems and Service Research at the College of Nursing and Health Professions at Drexel University. She also has an appointment in the College of Computing and Informatics, also at Drexel, as well as she's faculty in the Institute for Healthcare Informatics. A fun fact that I read is that between 1997 and 2000, she was Senior System Analyst here at Christian Care Health System. She obtained a DrPH from the Johns Hopkins University Bloomberg School of Public Health from the Department of Health Policy and Management. She also has a Master of Science from Johns Hopkins School of Medicine in Health Sciences Informatics, as well as an MBA from University of Pennsylvania Wharton School. And she also obtained a fellowship that was funded by the National Library of Medicine Informatics Training Grant and the Robert Wood Johnson Foundation at Johns Hopkins Medical School. Her research focuses on the development and implementation of health information technology evaluation frameworks and instruments, and the application of mixed methods approaches to improve the health of vulnerable people and of those who reside in under-resourced communities. She is currently the PI of an AHRQ R01, and we know how difficult those are to get. She has had multiple awards over the years. She also has a very long list of publications. She's a very popular speaker nationally and internationally. And she has many other responsibilities, including teaching and mentoring, really too many to describe. So I'm really excited, and thank you so much for being here.
Hi, good afternoon. Thank you so much for inviting me, Lisa. Thank you for making the arrangements. There's a little bit of everything in this talk. There is something for the people in the hospitals who are concerned about readmission within 30 days. There's something for the home health folks who know how difficult it is and how important the admission is and how difficult to get the information from the hospitals that they need. And then for the informaticians and the data people, I have numbers. So there's a lot of numbers. The talk is a little involved. So it may be best if you have questions to stop me and ask your questions so that we are all moving along together. So the title of the talk is Hospital to Home Care Transitions in Care, Informatics Opportunities to Support Nurse Decision-Making Through Improved Health Information Technology. So why study transitions in care to home health care, which I'll abbreviate as HHC? These agencies admit 12 million patients per year to home care. The services include nursing, therapies, and social work for homebound patients that can't leave the home, and clinicians operate independently in the patient home under physician orders. So as you can see, it's very different than on the hospital floor. The agency has challenges during admission. There's a mismatch of patient information between what the hospital gives them and what they need for the admission. Another challenge is timely and accurate data collection during the admission. And lastly, that 20% of home care patients are rehospitalized within 30 days of hospital discharge nationally. So where you see the little numbers after, that means there's literature to back this up. So our thought is that we may be able to reduce rehospitalization rate with better information, enhanced care planning, and allocation of clinical resources. And I'm going to focus on better information. So briefly, this is the process of hospital discharge to home health care admission. The hospital at discharge generates paper or electronic documents with all the referral information that they wish to send to the agency. At the agency, there tends to be an intake nurse who communicates with the hospital to make sure the patient is appropriate for the services that the agency offers and that the patient has insurance that the agency takes. Then a nurse is assigned to the patient to do a home visit during which they assess the patient and the home environment. And during this time, during the admission, they're going to make and document 4 critical clinical decisions. The ones in red are the ones I'm going to focus on. One is medication reconciliation, and the second is which problems to include in the plan of care. The other 2 decisions are important: visit timing and frequency of the subsequent visits by skilled nursing, and which agency services the patient would benefit from. Then once the plan of care is documented, there's subsequent visits by the nurses who come in and see the patient on a regular basis until the patient is discharged or transferred. So that's the process of the home care admission. And during the admission, there's a number of documents, which I'll be talking about. One is the referral document. It's either faxed as paper or electronically sent to the agency, and it can be either printed or added to the home health care electronic health record, EHR, which is then made available to the nurse. Then at intake, there's an intake document sometimes, and it's specific to the agency in terms of whether it's there, what the format is, and what the content. It's variable. Then when the nurse is in the home, the nurse can ask to see the document the patient was sent home with. We group these into the name of transition document, and it consists of discharge summaries from the hospital or the progress note from a physician's office. And this document has the patient's instructions on it. It's intended for the patient. And the nurse can ask the patient or the caregiver for it while they're in the home or not. And then finally, the nurse generates the plan of care. This is the decision of which problems will be addressed in the entire episode. And these are nursing problems. So it's assessment, education, and intervention. Also, which medications are the patients going to take, and the visit schedule for subsequent skilled nursing, and which services. Home care admission has challenges of its own. One challenge is the information transfer along the transition in care. So hospitals and other referring sites tend to have very different EHRs than the EHRs in the home health care agency, and these EHRs do not communicate with each other. Also, there's inconsistent content and form of information that's transferred from the referral site to the home health care agency. So every time the nurse gets the referral, it looks different if it's from different origins. And the home health care nurses receive only half the recommended data relevant to the plan of care, only half. Another challenge is that the nurse's time with the patient during that initial admission visit is constrained due to the nurse schedule, which is to see 5 other patients that day, and because of the patient's condition. They've just been discharged from the hospital, they are tired, they don't feel well. The last thing they really want is somebody else in the house. And another challenge is this Centers for Medicare and Medicaid Services requirement to document something called the Outcome and Assessment Information Set, or OASIS, which has about 90 items relevant to admission. This is not a checklist. This is choose one along a scale of either 1 or 2 or up to a scale up to 5. This needs to be documented in the EHR for the admission to be reimbursed. So in addition, there's other informatics challenges. There's lack of and uncertainty of information, which contributes to inefficiency and potential risks to patient care. The existing data interoperability standards are not required across the transition in care to home health care. So the meaningful use interoperability requirement that the hospital's working on doesn't apply to home care. The continuity of care document, which is an HL7 ASTM standard, it is a standard, and it summarizes and categorizes patient summary information as useful for transitions between institutions providing different levels of care as it was intended, but it was designed for the communication needs of physicians and not nurses. And lastly, we have the IMPACT Act, which will be implemented next year, which calls for actionable and imminent communications standard to implement standardized quality and assessment measures, except home care was just written out of the implementation. So we don't have tools. I'm going to talk briefly about one standard, the Continuity of Care Document Standard, CCDS codes. These are the codes in the standard. And so as you can see, there's some demographic information, functional status information, some problems information, can be in the CCD communication. Medications can be in the document, vital signs, procedures, plan of care. And so there's a potential to have quite a bit of information in this document that is not required to be sent to home care. So our study has approval by the Institutional Review Board at Drexel University. We conducted our observations between 2016 and 2018 at 3 diverse home care agencies in Pennsylvania. I did talk to Christiana, but we already had somebody on McKesson. The agencies were 1 rural, 1 suburban, 1 urban. They have different patient populations and different commercial point of care systems on a laptop that they bring into the home. And the study is to integrate findings from focus groups, observational studies, document review, and EHR comparison. And our intent is to develop recommendations to enhance the admission process in home health care and to inform HIT standards for home health care agency EHRs. So briefly talked about the 4 important admission clinical decisions that we're focused on. I'll talk about the 2 in this talk. One is the plan of care and which problems to include. The nurse decides which problems to include. And the second decision is medication reconciliation, which is the accuracy of the medication that's in the home and the patient's medication self-management capability. So you can see the difference from hospital medication reconciliation, looking at patient self-management capability. And so as you know, medication reconciliation is comparing the list of medications that came from the referring site to the list the nurse has in the home, and then finding all the pill bottles in the home and comparing what's on the pill bottles to what's on the list. So I have 2 major research questions that I'll talk about in this presentation. The first talks about the availability of information that nurses in home health care admissions said they needed. So availability of information that's needed. The second question talks about what the quality of the information they actually had. And that has 2 parts. 1, talking about the problems, and 1, examining medication reconciliation. And we examine quality by looking at congruity, which is similar, how similar the information is from referral to documentation and plan of care. Are there any questions so far? Okay, here we go. So the settings, 3 agencies. The rural agency was small, whereas the suburban and urban agencies were medium size. The rural agency was standalone. The suburban and urban agencies were part of health systems. The patients at the rural agency were majority white, lower socioeconomic status. The suburban agency had a majority white but middle socioeconomic status, and the urban agency had majority African American with lower socioeconomic status. They all had commercial point of care EHRs that ran on laptops. The rural agencies was from a company that provided EHRs to small agencies in the region, as far as Ohio. The suburban had an EHR from a nationally ranked company, and the urban EHR was quite interesting. It was a relatively new home health care EHR that was added to the product line of the leading hospital EHR vendor. So that tells you who it is, right? And in terms of interoperability, we had a few different flavors. So interoperability is the ability to electronically communicate information between settings, from one facility to another. The rural agency, being standalone, had no interoperability. The suburban agency could receive electronic referral documents only from their parent hospital in the entire health system, not from any of the other hospitals in the health system. And the urban agency had two flavors of interoperability. One flavor was with the 3 tertiary hospitals in the health system, the nurses received an electronic, actionable medication list. It actually had data. It wasn't a picture. Also, the nurses in the home care agency could view the data in the hospital's EHR. They could look up lab results. They could look up the weight. The other flavor in the urban agency was similar to that of the suburban agency, where they received referral data electronically from other facilities in their health system. 18 nurses participated, 6 at each agency. Most were female, but they were all RNs. They were generally middle-aged and had a lot of healthcare experience. So our first question, to what extent was information from the referral site that the home care admission nurse needed for 2 clinical decisions, was that information available to the nurse? So I'll walk you through the methods so you can see we really did the research. First, we conducted a focus group at each agency to ask the nurses what they wanted, what information they wanted for an admission. And then we observed the documentation of 36 admissions, 12 at each agency, both in the patient home and afterwards when they completed their documentation. Then we reviewed all the documents, and any questions we checked back with the nurses. So this is the schema of the timeline of the research. So before the home, we call the input phase, where we photographed the documents, the referral document, any intake document the nurse had, and any information on the EHR screens. And then when the nurse went into the home, that's the assessment phase, we observed. We did not stop anything. We just became part of the wallpaper while photographing the transition documents if they were accessed in the home, and hovering over the nurse's shoulder, taking pictures of the EHR screens, mostly the Oasis. So that's all before. Stage 2 and is also the output phase, where the nurses completed their documentation, or if they had completed it in the home, they walked us through. And they walked through the documentation talking aloud about the decisions they made, the information they had, what information they didn't have, why the EHR, what they liked about how the EHR worked, what they didn't like. And we photographed and video recorded the EHR screens, especially the plan of care. And at the rural agency, they had a team email that was outside of the EHR. We took pictures of that. So then our data analysis of what information the nurses wanted versus what information they had available. So our comparison standard was the continuity of care document, that list of codes that I showed you early on. What we did was we selected 22 codes from that document, and we mapped what the nurses said they wanted to those codes, and so that we could standardize. And we also conducted thematic analysis on the information, on the transcripts to identify major themes. And then in terms of reviewing the documents to look at what data was actually available to the nurses, that entailed looking at both paper documents and electronic documentation like the EHR screens and the team email. And on this, we conducted quantitative analysis where we characterized the availability of the data that's mapped to the CCDS codes. And we also characterized the availability of content of data related to the two decisions. And then the mixed methods part is that we mapped the qualitative data about what the nurses had, those themes, to the quantitative data of what data was available so that we could better interpret, because I think that having qualitative data gives you context for understanding the quantitative data. So our results. In terms of the data the nurses wanted, almost 3/4 of the codes in the CCDS were covered with respect to information to be communicated to the transition to home care. So the CCDS had about 3/4 of the information the nurses said they wanted. We found 53 themes, and what's in red is what's not matched to the CCDS. But otherwise, among the themes, there was one theme about caregiver, 10 themes about external resources that are needed, like food bank, one theme about the safety of the home environment, 4 themes about the home care agencies, such as the services available, 3 themes about medication reconciliation, and 7 themes about medication self-management, and 27 themes about the patient. So looking at the data that the nurses had at admission, let's look first at document quality. The referral documents were universally available. We had them for every observation. We saw there was no standardization across referral sources in terms of what information was sent to the agency or the data that was contained in the documents, the length of the documents, the organization of the documents, but generally the referral documents were many, many pages, 40 pages. And then looking at the transition document, which was the discharge summary or progress note, 3/4 of the admissions for which transition documents were viewed in the home had legible information, 3/4. And there was no standardization of the data on the forms. So looking at document content, the data that the nurses had as compared to the national standard, we saw that most of the codes of the CCDS were covered, except for one, patient guardian, which is probably not relevant to older adults. So we took the CCDS codes that mapped to the information from the focus groups and put them down on the horizontal axis here. And they are on the slant at the bottom of this chart. And on the vertical axis are the number of observations that had the code. And these are the codes that were for problems which need, the CCDS codes for problems that need to be included in the plan of care. And this is a graph of which of these codes were actually found in the documents. And it's a stacked chart, so each color is for a different agency. The bottom is rural, which is blue. In the middle is orange, which is suburban, and gray at the top is the urban agency. So as you can see, there's variation in terms of which information is found in the referral documents. Yes?
The numbers are associated with the tables?
Yeah, they're the CCDS codes. Thank you for asking. The numbers at the bottom are for the CCDS codes. So as you can see, the problems in medication on the far left, that information occurred in most of the observations, 35 out of the 36, whereas advanced directives occurred in 5 observations and did not occur in any of the urban observations, any of the urban referral information. So you see as the nurse is looking through the referral documents for information, there's a wide variety in the information the nurse needs. Questions? So we also looked at the medication CCDS codes. Similarly, we took the CCDS codes that the nurses in the focus groups had identified are the data that they need. We mapped this on the horizontal axis, and these 3 codes also occurred in the plan of care. So there's no new information here. It's just that the medication CCDS information is limited to these 3 codes. Functional status, to tell whether the patient can open the pill bottle, for instance, or has the cognitive ability to read the instructions, the plan of care that comes from the referral site, and the medication list. So let's move on to research question 2, unless there's questions. So research question 2A is, what was the congruity or similarity between the patient problems information received from the referring facility and the final plan of care problem list generated at the admission? So how similar was the list of problems in the referral documents as compared to what ended up on the plan of care? So we limited our analysis to the 5 most prevalent problems among the elderly in home care: medication regimen, cognition, respiration, circulation, and skin. And to provide a consistent set of problem terms across all the documents, we again did mapping. This time we mapped to a standard called the Omaha system, and specifically to the problem classification scheme. The Omaha system is a standardized nomenclature. It's a system. It's got signs and symptoms for 42 nursing problems in 4 domains. It's a widely accepted standard, and it's widely implemented in home care and community nursing. So we divided the documents into the 3 phases that I briefly outlined previously, and the schematic is at the bottom here. The input phase, which is before the home, the in-home phase when the nurse conducts the patient and home safety assessment, then the output phase when the nurse is documenting and completing the documentation of the admission. And each phase has its own documents. So the input phase has referral and intake documents. The assessment phase has transition documents when viewed, and information that the nurse collected during the initial home visit and documented in the EHR, in the OASIS specifically. And then the output phase, which has the plan of care and at the rural agency and email. Our analysis incorporated looking at the number of occurrences of each problem as calculated by phase across all observations. And then to look at the quality of the information, we identified 3 types of incongruity, dissimilarity between the input phase and assessment phase and the output phase. The first type of incongruity we call IA, which is that the problem was on the input and or the assessment and not on the output. So problem got dropped off of the plan of care, never reached it. The second incongruity is IO. The problem was on the input and the output, but not on the assessment, and so it wasn't documented when the nurse did the physical assessment of the patient. The third type of incongruity was that the problem was on the output, but never appeared on either the input or the assessment. So I also want to mention that there was a list of problems that only occurred on the input, but we did not include those in our analysis because we could not tell whether they were active problems or they had been resolved, so we did not include them. So in terms of the count of the occurrence of problems, the 5 selected problems listed in the table here occurred 119 times across the 36 observations, for an average of 3.3 out of 5 problems per patient or observation. And as you can see, 4 of the problems occurred most often, 26, 27, 28 times, and those are medication regimen, respiration, circulation, and skin, whereas the problem of cognition occurred less than half, about 11 times. We also noticed there were 27 observations that had a discharge summary accessible during the assessment. And on those, 67 problems were not identified until the home visit. 67 problems were not on the referral documentation and were only identified at the home visit. And we also know the discharge summary that was given to the patient did not have a complete list of problems as compared to the other 2 phases. So is anybody concerned at this point? Yeah. We really recheck these numbers. Then looking at the quality of the documentation in terms of incongruity of the problems, again using the same time frame. Incongruities occurred 59 times across just these 5 problems across the 3 agencies. So this table shows the incongruity type, the occurrence, what was the most frequent problem in that incongruity type, and whether that incongruity type appeared primarily in one agency or not. So the first type is IA, that the problem's on the input or the assessment, but not on the output. It dropped off the plan of care. That occurred 63% of the time. Over half of the time, a problem did not make it to the plan of care. And this occurred most frequently with respiration, which accounted for 35% of this type of incongruity and overall 22% of all incongruities. And this incongruity was evenly distributed among the agencies. The next type of incongruity was the IO. It was on the input, it was on the output, but it was not on the assessment. This occurred almost a quarter of the time among incongruities. Circulation was the primary problem this applied to, which was over half of this type of incongruity and 14% of total incongruities. And this mostly occurred at the urban agency. The third type of incongruity was where a problem just appears on the output, not having been on the input or the assessment. This occurred 15% of the time. This constituted 15% of the incongruities. It mostly occurred with the medication regimen, right? That's of concern. That was almost half of this type of incongruity and contributed to 7% of the total number of incongruities. And this mostly occurred at the urban agency. Remember, this is the agency that had interoperability of the medication list, where the medication list came across as actual data and populated the home care EHR. And yet there were incongruities. So our research question 2B was to look at the incongruity for the medication list. And this was the incongruity between the referring facility and the final medication list. So the phases are a little bit different here. It's stage 1, which is the before home and in-home phases together, and stage 2, which is documenting the plan of care. So a little bit different division of documents. Same documents, and we also, as part of our analysis, categorized the observations as to whether they were in network for medication list or they were out of network in that the medication list was not shared. And here, our data analysis of the medication reconciliation, we took a number of steps. One was to extract the medications from the documents. A postdoc nurse on our team did this. Then compare the medication lists from stage 1 and stage 2. And this analysis only included observations that had documents for both stage 1 and stage 2. There were some observations that did not have referral documents or transition documents. And we also analyzed phone calls that the nurses said they were going to make to the provider to ask questions about the medication reconciliation. We extracted and categorized data from the transcripts, not of the calls, but of the talking leading up to the call. And this analysis included only those observations with audio recordings. And then we analyzed the complexity of the medication reconciliation at the patient agency and network levels. We measured this by the number of medications, the number of changes in the medications from stage 1 to stage 2, and the number of provider phone calls that the nurses described to address these changes. And then we tested for the difference between in-network and out-of-network observations to see whether interoperability made a difference. So our results, we saw there was no standard format for communication of the medication list from the referring facility to any of the agencies. So each referring site had a different format for their medication list. We also saw that the nurses typed the referral site medication list into the home care EHR at the rural and suburban sites and at 3 urban out-of-network patients. So keep that in mind, how much typing they did. And then know that among these 36 observations, there were 35 observations. There were 447 medications documented. And there was an average of 13 medications per patient with a range of 1 to 32 meds. And the nurses are typing all this in. I'm not understanding the question. Can you? So we have a question from a remote audience member, and I'm trying to make sure I understand the question. Should we come back to it, or have they asked it? Okay. We'll continue, and then hopefully we'll have that question asked. Okay, so nurses are typing in a lot of medication information when you've got average of 13 meds per patient. We found when comparing the agencies that they were similar in terms of the medications, the number, the patient acuity, and the occurrence of differences in the medications across all agencies, which is important because that means that we can group all the agencies together in our analysis if we wish. We saw that most of the observations had differences between stages 1 and 2 of the medication list. So only one observation had the medication list from the referring facility the same as the medication list in the plan of care, which is understandable with that number of medications. We saw that the urban site, which had the interoperability, had the fewest changes. However, nurses call providers with medication questions most often, for about 83% of their visits. We also saw that 40% of medications had one or more change during reconciliation. So when we compare differences, medication differences between the input and the output for observations that were in network as compared to observations that were out of network is what is on this table. The items that are bolded have statistically significant differences. So any type of medication difference between stage 1 and stage 2 had a statistically significant difference between for the in-network observations as compared to the out-of-network observations. We also saw statistically significant differences in the change in dose or frequency of administration and change in time of day of administration. So I'll try to summarize this study. In terms of availability, we looked at the data the nurses want for problems in medications decisions, and it was mostly available across all the agencies and observations. The quality of data that nurses had was a different story. For the problems, we looked at 5 common problems, and that we found about 50% incongruity of the documentation from referral to plan of care. We saw problems being dropped off the plan of care. We saw problems that didn't appear in the assessment, and we saw problems that were only on the input and output and not on the assessment. And it's unclear to us during this analysis whether a referral diagnosis for what's usually a chronic condition, whether it was active or whether it was under control. We also, in terms of medication reconciliation quality of the data, almost all the patients and 40% of the medications had one or more difference during reconciliation. However, those observations that had a shared medication list with structured data was associated with reduced differences between input and output. And we also saw that over half the patients in 2 of the 3 agencies had problems with medications such that the nurse called the physician. So this shows the importance of communication across the transition and care chasm and the need for a standard communication of problems from acute care to home care, and the need for the documentation of problem modifiers such as whether the problem is actual or resolved and whether it's high or low priority. In terms of medication reconciliation, what we saw is, as we know, it's very complicated, especially when you have an average of 13 meds per patient. It's time-consuming, it's wrought with mistakes, and there are many drug changes from input to plan of care. We suggest strongly that the medication list needs to be cleaned up at hospital discharge, that the lack of interoperability necessitates manual transcription and documentation, which creates a high potential for data entry errors, and that a shared structured medication list may reduce differences and calls to physicians. So what are the implications for practice? We know that the timing of the first nurse visit to the patient home is very important, called front loading. And the earlier the nurse visits, the earlier any of these medication issues can be identified and acted upon to make sure the patient's taking the right medications. Another implication for practice is the challenge to the availability of high-quality data diverts nurse time and effort from patient care to information reconciliation during that first visit. Nurses don't have time to activate services that are offered by the home care agency that the patient needs. And this is really important because beginning in January, the length of a home care episode is about to be cut in half. And so it is really important that whatever services, whatever interventions need to be identified and started at that first home care visit are done. But this is very difficult when the nurse has all this other documentation work to do. So I'll close on that upbeat note and show you our references. I want to acknowledge the home care agencies and the nurses who participated in this study. The project was supported by an R01 grant from the Agency for Healthcare Research and Quality. The content of this presentation is solely the responsibility of the authors and does not necessarily represent the official views of ARC. And this is a picture of our research team. And we had undergraduates and postdocs and full professors from different disciplines. So, thank you, and I'll take any questions you have. Yes.
Great presentation.
Thank you.
So I do primary care, and obviously have a lot of I know you had mentioned in the urban setting that there was interoperability, but they haven't. And your sample size was about 12
right.
patients. I think that was because there were more meds that urban had, or was there any other characteristics that
Right, thank you. So the question was that the urban site had more phone calls to physicians, and did we have an explanation for that? So we do not have an explanation. We were very surprised by the increased number of phone calls. We saw when comparing across agencies that the urban agency was very similar to the other agencies. Same number of meds, same number of high-risk meds, same process for admission. We need to look at that further. And what we were not able to do because we didn't have consent was to record the phone calls. So we only know we have some further analysis about what the nurse said they were calling about, but that's preliminary data, and as you pointed out, very small sample size. So we don't have an answer, but that is one area that we're very intrigued by. Thank you. Yes.
One other question. So organizationally, right now, we have our own agency that's embedded, but there's no interoperability. Our own EHR that we control, and various other agencies. So I guess with the information conversation, best in interoperability and are at least from demonstrating it, some advantages to it, but it's more of a process. So like as we're engaging with some, are there things that we should talk about in the interoperability to that?
Another great question. So the question was about what we have learned about interoperability between the home care agency and the referring facility in light of Christiana's structure, which is similar to the urban agency, and however having different EHRs that don't have interoperability. So I don't know where the Delaware HIE is right now. And that should provide health interoperability to some level.
Yes, so there's all the hospital, all the, and all the labs, all the our health notes, every agency, but I know the bulk of it. So that information.
So the home health agency data is not part of the HIE. So there is one article in the literature with Brian Dixon at Regenstrief as the last author. I think Husani is how to pronounce the first author's last name. And that study looked at using health information exchange to pull the data together, and it was mostly VA data. And their first challenge that they attacked was the differences among the content of the documents, such that there needed to be this information reconciliation to be able to map the data together so you get a whole story of the patient. And they use the CCD code to do it and a piece of software. And so that is one problem. And we saw that in the referral documents, because for a single referral, we could have 40 pages, and we could have a set of documents from this skilled nursing facility and another set of documents from the hospital. And then the nurse is supposed to integrate this, right? Because it's different kinds of information about the patient. That is definitely a challenge. And in terms of your question about interoperability, at the urban agency, we did see nurses going into and tell us about going into the hospital EHR to look for information that they needed. They actually had a viewer, a couple of different kinds of viewers into this EHR. So they did use that. We suggest that interoperability would reduce the amount of transcription and the errors, and also the cognitive load and the effort that the nurses do with all this transcription. What we're not sure of, and what we would like to look at next, is the question of, if the information came across, would the nurses believe it? Or would they have to re-examine it for themselves during the physical assessment? And as a physician, you can understand that. You listen to what the patient reports, but you want to validate it for yourself. So would having the information in the record reduce any of the tasks or any of the thinking that the nurse undertakes? That is a big question. I don't know. It'd be nice to quantify it. But we do know that the nurses get less than half the information they need, and that they have to page through all these documents. So giving them the data, it can't be a bad thing. Is it worth the investment? I don't know. It's an excellent question, and maybe you want to do research about it. Yes.
Hasn't a lot of this work been done already related to interoperability? When I don't know if you got to the point after your research was done of pushing hard on the HL7, FHIR, those standards?
So the standards exist. They are not implemented in home care because there's no incentive or mandate or policy or reimbursement mechanism for the standards to be implemented. At the beginning of last year, we were really hoping the Impact Act standards would be implemented for home care, because that's how the act was written. And then it got written out of it. Frankly, hospitals operate on a narrow profit margin. Home care agencies operate on a narrower profit margin. So asking the agencies to have the technical capability for incorporating this information into their EHRs, I think is not an easy lift. And the home care EHR vendors don't seem to be very interested in this because the agencies are not demanding it. On our next project, if things work out, we will work with one of the leading home care software vendors to work on some interoperability. But it's a heavy lift for a sector of the home care industry that's barely holding on, and this all costs money, and it's very hard for the software vendors to justify it when the agencies aren't asking for it.
As a follow-up, then, if you look at the money that they spend as agencies on all of the typing that nurses are doing, how many nurses they have doing and spending hours typing, when they could spend a little bit of money on IT, fix this, and have it all transferred.
So at this point, I'll step away from the microphone, hoping I'm not going to be recorded, and say, yes, that happens, and nurses in home care are supposed to work at the have yet to see. They do their work, they see the patients, they go home, they make sure they feed the family, make sure the homework's done, clean up the house, and then sit down at the computer and finish their documentation. Then they look at the documentation. Yes.
You were talking about having the same. The world's largest healthcare hospital they have their own nursing. There is data on CTR, because that data is confidential.
So the question was, the VA system, which is the largest system, has a single EHR across all their hospitals, and they also have a large number of nursing homes, and has any work been done on the sharing of data between the hospitals and the nursing homes. So my area of interest is not nursing homes. I don't know much about that. There is a researcher with the last name of Alexander at University of Missouri who does nursing home research. I'm not aware that he does interoperability research. But what I can point you to Brian Dixon's or Husani's article, which talked about the difficulty of even integrating the data from multiple referral sites within the VA to give a unified picture of the patient. So, and I don't know the answer to that, and frankly, I guess it will all change when the VA goes to Cerner, right? Whenever that is.
And if I was in the VA system, for the first station, and I did have a patient who said he wanted more purpose, and he said because of other things. We were able to reach out to the San Francisco VA from Wilmington electronically and get his record.
Right, that was.
And to know that he was already getting.
Right. So you were able to, at the Wilmington VA, ask a question about a patient at the San Francisco VA. So that was hospital to hospital. And the question, your first question, was asking me about hospital to nursing home. And I do not know what they have implemented in the nursing home. I can tell you that just from the few observations I've made, I have yet to see full EHRs in nursing homes. So I don't know about that interoperability.
An opinion about the EHRs which private hospitals are using versus. I thought when I came here, I came to paper charts being used to electronic records. I was quite appalled. Now we have Cerner. I think it's a very dysfunctional system. Even now, a lot of broken pieces, and you have to join them all together and put them together. And so the question, maybe this is not in your talk here. Why do people choose Cerner or Epic, or what makes them choose?
So the question is about the quality of the hospital EHRs. Frankly, I think it's a marketing question. And I think that, and I also think there's a barrier to the free flow of information. So when I was here, you could ask a vendor for references. You could do a site visit. You could take pictures of the screens. That is now written in the contracts that you cannot do that. You cannot let somebody from the outside get that kind of information. And that is a barrier to the free flow of information from a prospective buyer to somebody who has the system, number one. Number two, think about how strong are the user groups of Cerner and of other systems. You mentioned Cerner, other systems. How much control does the software vendor have over the change management and listening to what the hospitals are saying? As compared, so we have the leading vendor, which is privately held, and the other vendors, which are publicly traded. So when you're publicly traded, you're trying to maximize quarterly revenues, right? So the stock price stays up. So they are weighing these. And so where exactly does the cost of making changes for the hospitals fit in? It's a good question. So I guess a couple of 2-3 years ago, my colleagues invited me to Bangkok, where there's medical tourism, And there's the public hospital that the king, who just passed away, went to. He was sick for a while. And then there were the private hospitals where mostly Saudi patients went. And the private hospital, which was gorgeous, unbelievable, they were in the process of implementing an English language EHR from America that I had never heard of, because it doesn't get any traction here. The market is already sewn up. And they knew what they were doing. And I haven't seen them, I may see them later this month, to hear how that implementation went and how that EHR is and how it is to use. But there is an article in the literature recently about 40,000 clicks that physicians and providers go through to order for the patients, and there are people trying, there's researchers trying to develop better interfaces, but how to get the vendors to want it. So better interfaces it falls in a field called human factors. And those are engineers. Ellen Bass and Yushi Yang on my team and Elise McLaurin are human factors people. And the large Maryland health system, whose name I can't remember, MedStar. So the human, pardon? Oh, yes. So they did a study of human factors and found that none of the vendors have human factors people, on their staff. So who's designing these systems? And we just had an example of a change. Someone told us about a change that needed to be made in the software we were studying. And the decision about how to implement that change, check boxes, bullets, drop-down menu, was up to the analyst. And the decision was, well, what's going to take me the least time because I have this list of things to do, as opposed to what's going to take the user the least time, because the incentives aren't lined up, right? So you've got it at the hospital level, you've got it at the vendor level. It's not pretty, and the lack of true competition in this country does not help, I think. So that's my opinion. I think we've gone over as I chat. Other questions? Well, thank you very much for your patience.